school nurses will see a child when they're sent to the health room because they've been scratching in class. And so the first thing the school nurse wants to do is determine whether or not there is an active case of head lice. There are multiple reasons why a child might be scratching their head, but school nurses tend to be very vigilant toward the identification of head lice. So the first thing is to actually examine the scalp and look for the presence of at least one live louse. It might be that the child's been treated at home and there may be some dead lice or nits still present on the scalp, but that would not be an indication of a live infestation. You would need to be able to see at least one live louse. So some things school nurses can do is certainly educate themselves on how to screen properly for head lice, and then be sure the information that they're sending home to the families are accurate. And that information needs to include such things as how to screen for head lice and when to screen. Parents typically, we recommend that they screen on a regular basis, but certainly before the start of the school year, winter breaks and spring breaks, whenever children have been in the community for extended periods of time.
As a physician, I view the school nurse as a super important ally in identifying these cases and bringing it to people's attention. You know, head lice get a lot of attention in school, scabies don't. And it may be that there's even more stigma attached to them. So, you know, it's important that the school nurses be able to recognize the symptoms. Yes, it's another itchy infestation. But here, you know, it's not the scalp, it's the body, it's the flexural creases, it's the folds. And in some severe cases, in some medically impaired children or immunocompromised, it may be their whole body. So that pattern recognition of the kid who's itching, but it's not just their scalp, is something the school nurse should think about. And they may know because often there's infestation within the family. So they may know that the sibling was just in for this. They may have seen it. They may have called in the parents. They can bring it to the parents' attention that they're looking for it. But scabies can be really difficult to treat. And because it's missed so often and often misdiagnosed by many providers, physicians, and others, it might help if they put together that story for the parents to hand it as a package to these providers so they get adequate treatment. Scabies can really be a bear. Less than 40% of the cases are diagnosed accurately, at least initially. And it's very tricky because these kids will present with an itchy rash. And when they have that itchy rash, you know, lots of things come to people's minds, common things and things without a lot of stigma, like poison ivy. So these kids may be treated with something for poison ivy or told it's poison ivy, and maybe it'll go away and use more care. And then someone might think it's eczema. Here, put on these emollients, try this, moisturize the skin, but they keep itching. And then the problem really gets there when they start applying steroids or given oral steroids, which seems to let this infestation really kind of take over and explode. And at that point, it may get multiple areas. The itching may get worse. And then finally, someone looks at the pattern and here's the history that the family has it and may diagnose scabies. But since we don't have any other approved, FDA approved topical treatments, there's up till now been very few choices for what to do. So you do need to find a good treatment for it. And then even when you're treated, the burrows may have droppings from the scabies mites in them, and the itching continues. And it's important, as Dr. Gordon talked about with head lice, to identify and to educate, tell the parents what to expect. Because the medicines that kill the mites aren't necessarily going to stop the itching immediately, which may last for weeks afterwards. So it's a very tricky disease. There's lots of pitfalls along the way. And the school nurse is very helpful by knowing this pattern and some of these pitfalls. He or she may be able to intervene and help these families out quite a bit.
I agree, Chris. The idea that parents need to be patient with some of these treatments, that the children do mount an allergic response to both of these parasites, and it takes a while for that itching to resolve. And because itching is so closely tied to both head lice and scabies, that parents think that because the child is still scratching, that the infestation is continuing, which can lead to overtreatment. especially in the case of head lice. We know that families often treat at least 5 times with over-the-counter medications before they seek the help of a healthcare provider that can offer some of the newer, more effective prescription items. So the school nurse can certainly work with the families to get a good history of what they have used, and then to encourage them to seek support and help from their primary healthcare providers. With the case of head lice, not everyone itches. So many times the infestation goes undiagnosed until it is very severe because the child doesn't have an allergic response, or they have a delayed allergic response. So very often children may have the infestation for 2 weeks to several weeks before it's even picked up. So those are concerns as well. And then parents need to understand, and school nurses can educate, that some of the products actually exacerbate itching. So they are scalp irritants, and so you have an irritated scalp, and then you apply a product that also irritates the scalp, which parents may consider is an exacerbation of the head lice, or the head lice has come back. So they develop what I have called an itch treatment cycle, where the child is itching, so they treat. The treatment exacerbates the itching. The parents interpret that as head lice is returned or not successfully treated, so they treat again. And then you can end up with very excoriated, angry looking scalps and secondary bacterial infections as well as a result of that. So again, school nurses can educate and help encourage families to seek assistance from healthcare providers. Anyone can get head lice. Mostly lice is transmitted head to head in the community, in the family and community settings. Less than 10% of lice infestations actually are transmitted in schools, but because lice are so frequently identified in elementary schools in particular, there's an association of lice in schools as being the major transmission area. And that just simply isn't true. So we need to help parents understand that they need to screen all the families members in close contacts. Some kids have time spent in more than one home. And so as they go back and forth between homes, they can spread lice back and forth, and you might get lice under control in one home, but not the other home. And again, not everyone itches. So you need to be screening everyone, not treating everyone, but screening everyone that is a close contact or family member for the presence of live lice. And again, it's only when there's live lice present that you actually treat, which is different from scabies.
Yes, absolutely. It is a little different. Again, similar kind of concept, but yeah, you want to treat those close contacts. Certainly everyone who's close at home or who shares a bed with an index case gets it. So it's universally, the whole household will need to be treated when it comes to scabies because of the contagion that goes on there. It is so easy to transmit. So I think that's a very important difference as we talk about those two, is finding them. But I find, like you said, with the complex social situations and multiple houses, sometimes I really have to dig and dig and dig to find out who these people are. And sometimes what we find is that, or that I find, is that people don't want to tell the sister-in-law where the kids go because they're afraid of being judged. And they don't tell this other person, those other kids aren't treated, and the cycle goes on.
That's true in school settings too. So the school nurses need to be part of the solution and not part of the judgment. And sometimes parents tell me that they don't want the school nurse to know their child has lice because they do have concerns that they'll be labeled or targeted. Now that is changing because we've been doing a lot of education over the past few years, but we're always working with school nurses to help them understand that that we need to be working on diminishing the stigma associated with lice.
Yeah, and I see it amongst healthcare professionals with lice or scabies. You mention it, and they freak out, and they want their gloves and their isolation gowns, and that these aren't pathogens. These aren't insects that jump or fly. They need close contact for prolonged periods. But when people say, oh, we're going to have to close down the room after you're in it for 4 hours, and oh, or we're going to have to close down the bus and send it, it's just, it drives that so much. So I think the nurse can help. The whole school district has to have reasonable policies for it. As healthcare workers, we need to educate our, my MAs, my nurses, other people to like, it's fine. You're not going to get sick with this from rooming a patient, and driving that stigma just makes people, it's a barrier to treatment. It's a barrier to treatment if you attach that stigma. Yeah, I agree. That resistance marker, the KDR resistance that gives resistance to permethrin, the most common in the pyrethroids, the over-the-counter meds, is present in 98% of the lice in the United States. That gene is there and is ready to do it. And that's really why I feel the time has kind of come and gone. If you fail at a permethrin once, you really got to give up on it. It's time to move on. We have so much more effective modern therapies now.
Well, I think because in many states, the children were not attending school, so they were virtually attending school from home. Many school nurses were not seeing the children. While the teachers were connecting with them virtually, the school nurses may or may not have been connecting with students virtually. It really was incredibly variable across the United States. I think the protocols for treating head lice remained the same because again, transmission occurs primarily in the home and in the community. Now, while some families were in a bubble and limiting their social interaction outside their immediate family or maybe their immediate friend structure, many were not. So it's too early to tell at this point what the outcome of COVID-19 is going to have on the number of cases that we see. It's certainly going to interfere with any trend tracking that school systems were doing in terms of numbers of cases. Some schools had the ability for the school nurses to have virtual telehealth sessions with families that diagnosed head lice on their own, or perhaps saw a healthcare provider and were diagnosed, and then to give them support in terms of their treatment approaches. Some school nurses were able to make home visits for families that were struggling. So there was an incredible amount of variability across the United States that depended in great part on the policies that were in place related to the school structure. But of course, the primary focus during COVID-19 was how are we going to deliver education during COVID, as opposed to how we're going to deliver school health during COVID.
I agree. And from experience, and I'm looking forward to seeing this data, I think some of the kids who would have normally been at school and separated, these parents had to work, they didn't have school to put their kids into, so they did band together and they went to family or other places where these kids were, again, in close proximity for all of the day, not having access to a school nurse, which makes it easy to transmit. It's a whole new set of group with more frequency. They weren't able to control scabies or head lice. And yeah, haven't seen data yet, but I'm very suspicious since most of the head lice transmission we know happens outside of school. I think we're gonna see increased numbers.
And we're just entering camp season.
Yeah.
The restrictions are being lifted. So that's really going to be a window into what has been happening with head lice and scabies over this course of children being at home for virtual education. Well, I think, Chris and I have been kind of tag teaming each other back and forth and demonstrating the importance of the relationship between school nurses and pediatricians and other primary healthcare providers. And it's very important that there is a good relationship. I think schools have been improving and in terms of forging relationships, ongoing relationships with their local pediatricians and primary healthcare providers. And I think you pick up the phone and you call. and talk with the families and get their permission to contact the healthcare provider. Some families don't want you to do that. So in my view, it's important that you approach it as a team, the school nurse, the parents, and the pediatrician or other primary healthcare provider.
And whether I'm answering the call from them or my nurse is, I think you just build a culture of collegiality, and we're trying to get help here to help this family out. And the school nurse may be saying, this family's tried permethrin 6 times, 8 times. It's not working. It's time to move on to a prescription med. I think it's important for the school nurses to know there are good prescription medicines these days where resistance has not been seen to be an issue, and refer them on. And then that provider can get the family in, confirm the diagnosis, and pick the most appropriate medicine for that child, as well as helping with some of that screening the other family members. Where are they picking it up? Why is it recurrent? I think that's all super important, and both sides have a lot of insight into this. And it seems that it causes so much panic. People want it gone now. They don't necessarily want to wait around for a prescription, or they don't want to tell anyone who's a prescriber to do it. And they either try over the counters, or they go, in my experience, to the kitchen, the garage, or the barn. And you see all kinds of things, like you're making salad on the kid's head, oily things, mayonnaise things, all kinds of things from the kitchen on their head. Unfortunately, in the garage, you see people using kerosene and leftover chemicals and leftover pesticides. Or, as you said, Dr. Gordon, going to the feed store and picking something that sounds like an approved treatment. And the whole point is not necessarily the active agent. The inactive agents, the delivery methods, can be really harmful to children since they're not given in the same way. So there's so much panic, and I think we need to have this open door policy that we'll take care of your kids. This is just an infestation. It's something that happens. It doesn't happen infrequently. We've all seen cases all the time, and treat it and get rid of that stigma so they can get in and good treatments that are safe, effective, proven in children. It's the way to go.
And a special caution for families that have very young children, infants, for example. You have to follow instructions on any treatment product that you're using, and use it in an age-appropriate way.
Yeah, for sure. Those young infants have a higher surface area to volume ratio, so they have more potential for skin absorption. And then another group to think about are pregnant women, or women who have a lot of children and small children, because each child may get a small exposure to whatever the over-the-counter or prescription treatment is, but that mom's put it on each kid's head. So she may get 4 or 5 hand exposures to it. So you got to think about how the safety of these medicines, even to the people delivering them. Part of the reason with the shampoos and the creams and the rinses and those sorts of things, we use cold water, is to not vasodilate and to not absorb extra medication into the system, which, as you pointed out, with small babies is even more likely to happen. You want to keep things pretty cool and not vasodilate and pull more of that agent into the child's bloodstream. So if someone's in the office for scabies, and it's these younger children, as we talked about, they have higher surface area to volume ratio. So they have a lot of skin exposed to soak up medication, and they have small blood volumes. So things tend to get more concentrated in young kids. And when you're looking at treatments that you're going to apply from the neck down to almost the entire body surface area, 91% of it, parents should be worried and asking about how much of it is absorbed, what's the toxicity of it, how long do I leave it on, how do I rinse it off? Because again, potentially for some treatments, that could be an issue. And you do want to know about the safety. Does this agent make it through the deeper layers of the skin, or is it contained in the skin where it's not going to get in the bloodstream? Really, these safety issues are very important in considerations. And I would hope that family thinks about that too, and realizes as they're treating their child, as Dr. Gordon said, not reapplying, not leaving it on longer, not thinking more is better. because some agents have the potential to be absorbed and have toxicity, and some do not.